everyone, and welcome. Thank you for attending this webinar with Fullscript and Advanced Orthomolecular Research today. My name is Kaylee. I'm part of the marketing team here at Fullscript, and we are very excited to have Dr. H. Singh here today with us to talk about how practitioners can leverage antioxidants to improve fertility outcomes for their patients struggling to conceive. Before we get into this presentation, though, I just want to remind everyone this is being recorded. This webinar is being recorded. And so all registrants will get a copy or access to the recording after the event. Whether you have to drop off early, don't worry, you'll have access through your email, as well as this webinar will live on fullscript.com/webinars. So you can always access it there. And we'll provide any resources as well as that we can when we send you the follow-up. Also, we will have a live Q&A at the end of the presentation with Dr. Singh. So on your dashboard, you'll see a question section. Ask your questions throughout the presentation through that kind of section, and we will get to them towards the end. We'll try to get to them throughout as well if we can, but we'll try to save some for the end for live Q&A. So again, I'd like to thank Dr. Singh for being here. Dr. Singh is a graduate of the Canadian College of Naturopathic Medicine and a licensed naturopathic doctor in the province of Ontario in Canada. He is passionate about supporting patients in optimizing their chances when undergoing assisted reproductive technologies or trying to conceive on their own naturally. He currently works at the Nutrichem Naturopathic Clinic in Ottawa, Ontario, Canada, and he serves patients from all over, but Ottawa, Toronto, Montreal, and has helped patients visiting internationally seeking fertility treatments. I could go on, but I know you'll get to hear from Dr. Singh, so I'm going to pass it over to you, Dr. Singh, and I will pop back in for the live Q&A towards the end.
Thanks, Kaylee. Thanks, everyone, for joining us. Fertility is a passion of mine, so I have the privilege of focusing my practice. 99% of patients we see are patients trying to conceive, and working with fertility has been a privilege specifically because we get to work to help patients really fulfill their dreams. And from a science background, my favorite part of working with fertility is there's not really a gray area. We either know it works or it doesn't when we're looking at the treatments. And this is kind of where I've seen certain topics in research emerge that have kind of been given the cold shoulder from the conventional aspect, and not completely, but we see that there's a growing ground for things like the microbiome, for hormone balance, for certain nutritional deficiencies, and very specifically here, as we're obviously talking about antioxidants and their impact on fertility. So this is something that we have seen how leveraging the correct nutraceuticals at the correct therapeutic dose can make a game-changing difference for a lot of our patients. And so this presentation is very much focused on certain nutraceuticals. We're going to talk about capsules, pills, milligrams, whatever, but really what we're talking about today is nothing less than changing lives. And this is what we do when we work with fertility patients. And this is something that is only going to become more and more prevalent now. And I think it's very short-sighted for patients or for people in general to look at, for infertility rates are growing, 1 out of 6, and couples are expected to experience infertility. We're seeing how fertility over the years for sperm health is decreasing. And we're seeing that, it's in conjunction with a lot of other health conditions like diabetes, metabolic health, changes in our environment, our diet, the standard North American diet. So we start to see a lot of these changes. And so, fertility is very much part of that picture. And we have to look at how can we support patients, not just, from the reproductive aspect, but taking into account the big picture of the environment and their lives. And so my profession, I believe, as naturopathic doctors, are perfectly positioned to help bridge this gap in knowledge, bridge this gap in treatment experience, and bridge this gap in providing, I would say, life-changing advice for a lot of these patients that have, in some cases, been trying for over a decade to try and conceive. So, I just want you to picture, imagine a couple who's done their 4th or 5th IVF now. They've taken out a second mortgage on their house, and nothing has changed in their outcomes. They're still seeing the same decreased, either egg quality, embryo quality. They're not getting pregnant, and the fertility clinic continues to tell them, let's try again. And there's not much change being done. These patients have their backs up against a wall. They don't feel like they're being heard. They don't feel like anyone's really pursuing, any type of effort to really make sure and figure out what's going on. And they don't know. It feels kind of like gambling at that point. Is this treatment going to work or not? So oxidative stress is one of those groundbreaking aspects of how we can support fertility. And we'll get into detail about that in much more detail. And so with the research that's been emerging on this topic, it's one thing when we see it in research. It's another thing when we see it in clinical experience. And this is something we see, or I get to see in clinical experience every day. So that couple that is now preparing for their 5th or 6th IVF and ends up conceiving on their own, it's not really an exception anymore. It's something we see very commonly. And this is something for patients we've seen, that are pursuing treatments in South America, South Africa, South Asia, across Europe, across North America. So treating infertility, really, we need to step up for our patients because they really need our support, and it's up to us to be there for them and to provide them with evidence-based guidance on how to do this. So many patients show up to supplement stores and like, oh, they prescribed me 1, 2, 3, 4, 5, 6, 7. It's like fantastic. None of them have the therapeutic dose that's used in the clinical studies. So it's very much focused on what are the right treatments, what are the right doses, what's the right treatment length, and who's the correct patient for these supplements. And just to give you a comparison, like they did a review on online marketed supplements for male fertility, for example, through online web spaces, and they found that I think over 80% of supplements did not even use ingredients that were evidence-based, and of the ones that did use some of the ingredients that were evidence-based, a large portion of them failed to even use close to the therapeutic dose. So it's not just about showing up at a supplement store. It really takes a healthcare provider to give that kind of clinical advice to a patient. So we'll jump right into it. Carnitines are an incredible tool to have, especially for male fertility or sperm factor fertility. And there's a bit of debate on how carnitine may help or what it specifically helps with. But very consistently, what I see in practice is the increase of sperm motility. And this is, one of the main 3 basic sperm parameters we look at. So we look at either sperm concentration, sperm motility, and sperm normal morphology. And a lot of the time, patients kind of get this test done, and the clinic kind of just puts a check, check, check. Well, it's good enough, you're good to go. But what we don't really have a conversation around with patients is actually your sperm motility is one of the best indicators of oxidative stress in the seminal fluid. So if there's an increase in oxidative stress, one of the first things we'll see in the sperm parameters is a decrease in the sperm motility. So you can see that this is not just about increasing motility, it's about changing the actual environment in which the sperm is present there, and that can have far-reaching benefits. Another review published looking at almost 22,000 IVF cycles in patients, and I believe it's done across the states. But just a decrease in sperm motility was one of the most significant predictors, statistically significant predictors of poor IVF outcomes and decreased likelihood of pregnancy. So sperm motility isn't just, fantastic, they're moving, they look great. It's actually telling us what's going on a biochemical level in the seminal fluid. And so for sperm fertility, we want to look specifically at all of these different parameters, particularly with morphology and motility being of higher importance when it comes to determining the oxidative stress in the seminal fluid. So I'll go through a few of the studies there, kind of highlighting the use of carnitine for sperm factor fertility. And this is kind of where the debate is. Some patients might notice that there's an increase in normal morphology. Some patients might notice there's an increase in motility, or I'd say most patients would notice that. Some might notice an increase in the concentration as well. So we have a study by Balseri et al., and that was done where they just did L-carnitine, by the way, no acetyl L-carnitine there, and they just saw an increase in normal sperm morphology. And then vice versa, when they treated with just acetyl L-carnitine, they saw an increase in sperm concentration. So motility wasn't observed to have increased or changed in that study. Lenzi et al. Did another one. This is actually the key dose that's used therapeutically, I would say, and I would see, doing thousands of consults, we see a great many number of patients see an improvement in their concentration with this dose. A combination of 2,000 milligrams of L-carnitine combined with 1,000 milligrams of acetyl L-carnitine per day, and did that for 6 months, and they found a significant increase in sperm motility, which is the main sperm parameter we see or observe to change. So, L-carnitine and acetyl L-carnitine are slightly different in their mechanism of action. Particularly, acetyl L-carnitine has a capacity to cross a blood-brain barrier, and L-carnitine seems to exert more, I would say, local effects near the sperm, energy production, and acetyl L-carnitine can definitely mimic some of those mechanisms of action, but it has a therapeutic advantage by crossing the blood-brain barrier and working actually on the hypothalamus and affecting the secretion of other hormones like FSH and LH. So we do see that particularly in a separate group of patients that we'll talk about shortly. So Lenzi et al., again, they did another study. They did a washout with this one. So they did L-carnitine for 2 months, washout, and then acetyl L-carnitine, or placebo, sorry, L-carnitine, not acetyl L-carnitine here. And they found an increase in sperm motility, again, in sperm concentration as well. Now, an important confounding variable here is how many days do the patients wait before they actually provide their seminal fluid sample. So usually when you go to a lab, at least here in Ontario, Canada, they'll tell you 2 to 3 days abstinence, show up, give your sample, and we'll see where those numbers are. But what we're seeing is actually a number of days a patient waits before they give their sample can greatly affect how many, the sperm motility in particular. So we see patients who have asthenozoospermia or low sperm motility actually shortening that period of abstinence to 24 hours instead of 72 hours will actually reflect an increase in the sperm motility. And that's hypothesized to be because of a decrease in the amount of time the sperm cells are actually exposed to oxidative stress in the seminal fluid there. So in one of the studies, they unfortunately didn't mention how long they were waiting before collecting the seminal fluid sample. So that's a potential confounding variable that in one of the studies. So overall, we're seeing from Lenzi et al. And Balseri et al., they're 2 studies from Lenzi, they're seeing an increase or favoring experimental group when it comes to progressive motility. So progressive motility is different from just sperm motility in general, because sperm motility means it's moving, progressive motility means it's showing forward movement specifically. So movement is great, but if it's going in circles because the tail is attached at an angle, it's not really going to be as efficacious for actually conceiving. So progressive motility is the main parameter we want to look for, and usually we want above 32%. Same thing with sperm total motility. So this is where they're combining progressive and non-progressive motility, so just total motility favoring experimental group again, and then the sperm more normal morphology again favoring the experimental group. And morphology, speaks more to the DNA integrity of the sperm cells as well. So we look at, sperm cells in general, if they have a normal looking form above 4% by the World Health Organization threshold there that they've set, that's considered normal looking sperm overall. But that number has, they've really set the bar low, because over the years, that number used to be a minimum of 80%. By early 2000s came down to 50%. And now the minimum we ask for in a seminal fluid test is 4%. So that bar has really come down over the years. And it's not just about, does it healthy looking sperm, but it's directly correlated with the DNA integrity of the sperm cell itself. So if the sperm morphology is looking healthy, if the sperm morphology is above 4%, usually we're seeing okay DNA integrity, lower DNA fragmentation rates. But if that sperm morphology starts to drop, then we'll start to see usually a decrease in the DNA integrity of the sperm cells. And this goes beyond fertility, by the way. This is like, we're seeing research how the DNA integrity of sperm cells isn't just about conception. It seems to significantly impact the risk of miscarriage in the first trimester. And we're seeing correlations where higher DNA fragmentation rates from the sperm cell is actually correlated with an increase in risk of for things like cleft lip, cleft palate, congenital heart and lung malformations, increased risk of certain childhood cancers. So we're seeing that DNA integrity may actually have a much bigger role than just getting pregnant. It may have a huge role in the first trimester for reducing potentially the miscarriage risk, and may help with the health of the offspring. And nature is incredible. And one of the wonderful things about conception is that DNA from the paternal side is actually delayed in its expression by a week, by a few days. So we call this a late paternal bloom. So as soon as conception occurs and implantation occurs, it's usually a few days later that the paternal DNA will be more heavily expressed. And that's where we start to see if there's a high level of DNA fragmentation in the sperm cell, there may actually be an increase in the risk of miscarriage, unfortunately. And the number of patients we have seen with consecutive miscarriage after miscarriage, and they've done the genetic testing for the baby, they've done hormone tests, they've checked for clotting disorders, nothing showing up, doctors have their hands in the air, patients are incredibly frustrated. And like just this past summer, we had a patient who had 5 consecutive miscarriages, and she was like, this is it. Like one more pregnancy, one more miscarriage, and that's it. Like she was done. And I said, that's great, your blood work, blah, 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 fantastic. Bring your husband in. Oh, but they told my husband his numbers were okay. Bring your husband in. And motility was lower than 32%. So immediately I'm thinking oxidative stress is probably high. Morphology was low, and treated the husband, pregnant in 4 months after treatment. So past the 72 to 74 day threshold. And now she's in late 3rd trimester. I'm waiting to give birth to her. That was the first time she made it past the 1st trimester. And we see that, again, this is not like an exception. This becomes the rule, what we see more commonly. So, and perhaps it's biased, the patients that, have very obvious other conditions like hyperprolactinemia, for example, that might be contributing to the risk of miscarriage, are probably, detected from it's probably detected by their reproductive endocrinologist. But I find male partners often get a break. They're kind of sitting on the sidelines often because, they said numbers are good enough, it's great. But when we take a closer look, actually, it's not the case. And we need to start advocating for this more often because your patients want to hear it. They want to hear that both partners have an important role in this fertility journey, which should be common sense. And B, we're seeing the statistics now where, including your partner may actually be the cost-effective thing to do. Reducing miscarriage risk, especially with IVF. Patients that go for IVF over and over and over, if they can, get pregnant with one of the earlier ones and not have to do this possibly again, that's a huge component of supporting long-term success and not wasting frozen embryos that they may have. Now, PCOS, this is something that carnitines have a huge potential benefit for. What are the biggest obstacles we have with PCOS? Well, number one, are patients even ovulating? This is the first barrier. So patients, we see Clomid, letrozole, fantastic. They ovulate, the 1st month, 2nd month, oh, 3rd month, didn't really happen. Let's try again. Oh, now we're gonna have to do a higher dose. So patients aren't often told, but they'll actually have a bit of a diminishing effect there as you continue to use ovulation induction with letrozole or with Clomid. So patients often become fatigued. I try and explain it to them and say, your ovaries are tired. They're working overtime trying to ovulate every cycle. And then the meds that are doing it are kind of like bathing them in FSH or LH with the changes in the hormones, trying to get that follicle to grow. So that's one of the big barriers we see. And carnitine is one of those things that's been shown, if you use it, actually from day 3 to 7, or up until the ovulation induction, like Ovidril, it can actually increase the ovulation rate. We can start to see a greater number of follicles that are reaching The true size of 17 millimeters, a cutoff that some of the studies use now, where it looks like, a follicle that's probably going to mature, ovulate, and has a chance of becoming fertilized. And most importantly, this doesn't happen with all PCOS patients, but I'll tell you, the ones that have this issue, they really struggle. So it's a thin endometrial lining. So if the lining is thin, we really need to look at what else we can be doing to support patients, and Carnitine is one of those supplements that's been suggested to potentially increase the thickness of the uterine lining, among other therapeutics as well. And one thing about PCOS that I don't think many practitioners are unfortunately aware of, it's estimated that up to 40% of patients with PCOS actually have underlying hypothalamic hypogonadism. So sometimes I look at the blood work and go, wow, FSH and LH ratios look fantastic, this might not be a case of moderate or severe PCOS, looks pretty mild, but there's actually underlying hypothalamic hypogonadism, and that might be through the levels of cortisol, through prolactin levels that are elevated. There's a few hypotheses out there, but acetyl L-carnitine has particularly been studied to help with patients that have hypothalamic hypogonadism, particularly in athletes. So just using, I believe the dose they used was about 1,000 milligrams a day of acetyl L-carnitine, they start to see increase in the FSH, LH secretion, and they would start to see an increase in ovulation rates there and spontaneous ovulation, obviously. So this is something we also have to look at for patients, especially patients who have resistant PCOS, where they're ovulating, they're doing the treatments, but they're not getting pregnant. So we have to start looking at, why is the estrogen or progesterone low? Why are they starting to have this thin uterine lining? So not every PCOS patient is the same, and we need to start screening for hypothalamic hypogonadism. So if you have a patient that has, FSH LH ratios that are fairly equivalent, we're not seeing that classic elevated LH, we need to have a closer look there, right? 3,000 milligrams of carnitine versus placebo, so they use that from days 3 to 7. And some other trials will use 2,000 milligrams every 12 hours. That's a pretty high dose, in my opinion. 3,000 milligrams is as high as I usually go to avoid nausea or digestive upset for patients. And just looking at some of the outcomes from this study, 54.5% of patients in the treatment group were able to conceive, compared to 5.8% in the control group that didn't use the carnitine. So we see carnitine can have different effects in the body, particularly with systemic. We see probably more well-known roles for carnitine, that it can affect support metabolism, increasing beta oxidation of long-chain fatty acids. We can see can reduce oxidative stress, specifically for reproductive functions. It's the antioxidant function that seems to be quite beneficial. May again for sperm motility, may also help with increasing ATP production, and actually has an anti-inflammatory effect as well, so reducing some of those pro-inflammatory cytokines like TNF-alpha, interferon gamma, interleukin 6, interleukin 2, etc. Melatonin, this is one of my favorites, and patients will always talk about CoQ10. They love CoQ10. My doctor told me CoQ10. Naturopath told me CoQ10. I was on the forum, they told me about CoQ10, and no one's really talking about melatonin. And talk about cost effectiveness. Like some of the results we see from these studies, and the systematic review in particular that was published in 2020, like over 40% increase in chances of pregnancy with a supplement that costs $10 to $15. You talk about a treatment cycle that costs $20,000 to $25,000, and we're talking about, hey, here's this thing that costs $15, and it might increase your chances of having high quality embryos and increasing your pregnancy rate, by 40+% compared to patients that don't use it. Unbelievable. So the systematic review published in 2020, 10 clinical trials, and specifically looking at patients who were going for assisted reproductive technologies, no natural cycles here. So looking at IVF, intracytoplasmic sperm injection, so where they're injecting the sperm into the egg, so they're forcing fertilization for patients that have poor sperm motility, and then insemination. And they looked at various doses, 2 to 8 milligrams. Now, surprisingly, no clear benefit of a higher dose over a lower dose. So even using a low dose seems to be just as effective. You see me sipping a lot of fluid, so I get very excited, and just keep my throat nice and hydrated. The other thing about melatonin is, very high safety profile. So we're seeing perhaps it might, increase lucid dreaming or vivid dreaming. They might wake up, they might 15 to 20 minutes of brain fog, grogginess, but really beyond that, incredibly high safety profile, and particularly for patients that have diminished ovarian reserve. Now, why is this so important? Why are antioxidants such an important role? Why would it have such an important role with fertility to start with? Because one of the main mechanisms we see by which egg quality and sperm quality decline with age is a decrease in antioxidant capacity. So we'll see after the age of 35, the amount of antioxidants present in the follicular fluid of the ovary, which is where the main antioxidants should be concentrated, they start to decrease. So there's nothing protecting the eggs, or very little protecting the eggs, in way of reducing risk of oxidative stress and fragmentation rates for the follicles. So can we give any antioxidant? Well, not necessarily, because we have to make sure the antioxidant actually concentrates in the follicular fluid of the ovary. If it doesn't concentrate in the follicular fluid, why are we giving it in the first place? Because we're treating here egg quality and reproductive health. So we want to make sure it actually reaches a target organ. So melatonin is one of those things we see actually concentrates reasonably well in the follicular fluid of the ovary there. And they saw, just by using melatonin, this looked at 10 clinical trials at a systematic review. Overall, the biochemical pregnancy rates, the number of patients that had a positive blood test with a beta HCG, 65% higher compared to patients that didn't. And the number of patients that made it to their first ultrasound, were they able to detect the heart rate, everything looked normal, blood test is positive, that's a positive clinical pregnancy. So 43% higher chances of a positive clinical pregnancy compared to patients that didn't use the melatonin. And increasing the likelihood of having more mature eggs and number of good quality embryos. So fertility preservation, this can make a world of a difference for patients that are postponing their conception and childbearing years to later, that are looking to freeze eggs in the near future there. And for this study, in this systematic review, looked at patients who had unexplained infertility, PCOS, diminished ovarian reserve, low egg quality, or it was not specified what they were actually diagnosed with. And the types of protocols, the medication protocols that we're using for patients during their IVF, IUI, or ICSI were both. So they had GNN, gonadotropin-releasing hormone antagonist protocols, such as cetrotide, or GnRH agonist protocols, such as using Lupron. Now, some of these studies did mix a few other ingredients. It wasn't just pure melatonin. They actually added a bit of myo-inositol and folic acid into the treatment as well. So potentially confounding results for those 3 trials, but the other 7 trials, including the systematic review, just had the melatonin. So overall, we're looking at the mean difference there for patients reporting top quality embryos. So we're seeing favors control there. With the figure 7, so meta-analysis, this we're looking at the biochemical pregnancy rate. We see that the biochemical pregnancy rate actually was again, favors control there, and favors control again. So for melatonin, we see that melatonin can exert 2 different actions there. One is through the receptor and one is direct, so in the follicular fluid there. So it can bind to either melatonin 1 or melatonin 2 receptors, and it can support oocyte maturation. It can affect epigenetic changes. It can also induce antioxidative enzymes there. And as a direct antioxidant, melatonin can help to increase cellular integrity, decrease apoptosis, and potentially affect oocyte maturation, support fertilization, embryo development, and may translate to implantation rates going up and pregnancy rates going up there as well. Now, same thing with seminal fluid. So, does melatonin actually concentrate in the seminal fluid of the testes, and we do see that. So melatonin does seem to cross the blood-testes barrier. Very low risk of toxicity for the testes, and we are seeing a lot of in vitro and animal studies, so not a lot of human trials yet, looking at how melatonin may be beneficial in reducing oxidative stress and supporting sperm preservation as well. Vitamin D3, so this is fairly relevant for Canadians, I find. And this is a common thing we'll see in practice as well. Does a patient have low ovarian reserve, low AMH, or do they just have a vitamin D deficiency? So anti-Müllerian hormone. We see that in research, if patients have lower vitamin D levels it can lead to lower AMH levels. And AMH, anti-Müllerian hormone, is a hormone produced by follicles in the ovary there. So we do see, AMH is often used as a marker for patients that are considering fertility preservation, also that are looking at, what are their chances of succeeding with IVF. Sometimes the AMH is checked too to help determine their egg reserve. It's never checked on its own usually. It's usually combined with FSH, it's combined with an ultrasound to check for antral follicle count. So we have multiple tools or tests to help evaluate what the overall egg reserve is. But AMH is one of the more consistent markers. But one thing that can cause it to really fluctuate is actually vitamin D status for some patients. So we see that vitamin D actually affects a lot of the enzymes responsible for sex hormone production. It has been associated that low vitamin D levels may predispose patients to premature menopause with lower sex hormones. Vitamin D observed to also affect progesterone and estrogen production. So it does affect some of the enzymes there in the adrenal gland and aromatase as well, which can be found in the ovary and again in the adipose tissue. So vitamin D supplementation is recommended for patients specifically with low vitamin D, but also patients with potentially low AMH. So if a patient comes in, they have low AMH, one of the first tests I'm running for them is actually serum vitamin D, just to make sure that isn't the cause. And I'll give you an example of many, but I had a patient come in and she had done 3 IVFs and she had stored over 30 frozen eggs. And the reason she did this is because the fertility doctor checked her AMH and said, 35 years old, your AMH is very low. If you're considering childbearing later on, she didn't have a partner at that time, you should probably freeze some eggs. So this kind of sent her down a downward spiral. 30 eggs is a very large amount to freeze for fertility preservation. And then when I saw the AMH levels, I said, just check your vitamin D. When you live in Canada, the levels can be often quite low. She wasn't supplementing, so it was very low. So she did have deficient levels of vitamin D. After supplementing for about 2 to 3 months, the AMH was perfectly within the normal range. So it's one of those questions, like, did that patient actually have low AMH? Like, was it actually indicated for her to pursue 3 IVFs and freeze 30 eggs? Or, could she have waited? Could she have done less? But her egg reserve actually was quite better. And so this is something to consider for patients with low AMH as well. And AMH isn't just a marker, it actually isn't just an inert kind of thing just sitting on the side. It has an active role in the follicle development. So I think of it as kind of like the brakes on a car. If the AMH levels are low, it's really not slowing down the follicle production. So we'll see follicle production will accelerate. So instead of ovulating around day 12, 13, they might start to ovulate day 10, 9, around there. And this rapid acceleration in follicle maturation and development can actually contribute to lower quality eggs as well. So slowing down that maturation or growth of the follicle to kind of a more normal range of days in the cycle can actually translate to better quality eggs as well. And same thing with for men, we actually see for sperm health, the vitamin D status can have a significant role, and we'll chat about that in just a couple slides there. So, who does vitamin D benefit? No, it's not something you need to start supplementing every fertility patient with, but we see specifically patients with low AMH might benefit from vitamin D supplementation, and same with patients with PCOS and or insulin resistance. So not both. If you have patients that don't have PCOS but they do have insulin resistance, might be something to consider as well. And so with PCOS, we see that giving vitamin D is actually related to improved insulin sensitivity by modulating the production of insulin receptor and increasing expression there. And we can see it also suppress some of the inflammatory cytokines that may worsen insulin sensitivity. So we're suppressing some of those underlying causes of insulin resistance for patients that have underlying increased inflammation. So vitamin D can have that kind of dual effect there. And also with AMH, I think it's pretty incredible how a simple vitamin can have so many roles in just one target organ there, by the way. This always blows my mind. So with AMH for PCOS, we see PCOS patients have too much AMH. So usually with the cystic ovaries, higher follicle count, the AMH production is much higher. And we have the opposite, where we're hitting the brakes too hard. So patients may stop ovulating. So AMH actually has a role in that. So by giving a little bit of vitamin D or correcting deficiency, we actually see that vitamin D can reduce the production of AMHR2 receptors and reduce the impact this high level of AMH has on actual follicle growth. So this is very important because now we're letting more of these follicles actually join the growing follicle pool, and they have increased sensitivity to FSH, which is that main stimulatory signal for the follicles to actually grow and join that dominant follicle pool. So we're seeing that vitamin D may not only does it impact AMH levels, but it can also impact the production of those AMHR2 receptors on the ovary. And we see specifically, patients who have vitamin D deficiency actually have double the expression of AMHR2. So they are very sensitive to even low levels of AMH, and that may affect ovulation there, specifically in PCOS. Similarly, patients who have fibroids, patients who have endometriosis, we see a potential, very vital role there for vitamin D there as well. So some studies finding that vitamin D can actually reduce the fibroid cell proliferation. It can suppress tumor growth by upwards of 12% with just a simple vitamin there. And particularly with patients of an African American background, they're both at a higher risk of decreased serum vitamin D levels because of higher melanin levels in skin, and then also increased risk of fibroids. But we also see patients of African American descent actually have lower levels of COMT enzyme in the liver as well, which is very important for liver metabolism. So we see even, this is mentioned in Yen and Jaffe's Reproductive Endocrinology, which is a textbook that REIs will study from during their fellowship. It actually has a little section there dedicated to how vitamin D can impact the expression and activity of COMT and affect estrogen metabolism there for patients of African American descent specifically. So, and we see with endometriosis, it's inversely, the risk of it is inversely related with vitamin D as well. And that seems to be related to the suppression, again, of those inflammatory cytokines. And so for endometriosis to persist, it needs a very specific environment, right? So we need usually higher levels of unopposed estrogen. This is like, jet fuel for endometriosis. So patients who have lower levels of progesterone are spotting like a week before their period and have a lot of PMS symptoms. So we'll see that these patients usually have higher levels of estrogen relative to progesterone, and also the presence of inflammation. This is kind of a prerequisite for endometriosis to persist. So the presence of certain cytokines will prime the surrounding local tissue for the endometriosis to grow and spread. And it's part of the mechanism of action by which it actually interferes with fertility as well, because the complement system activation through endometriosis is highly toxic to sperm cells. They will rip through the heads of sperm cells. So, if there's patients who have endometriomas, the secretion of these cytokines and the complement system, like it can prevent, sperm cells from even reaching the egg and the fallopian tube. So really, where's the opportunity there, for fertilization? The likelihood of that happening goes way down. So we see that just by increasing vitamin D, we may actually be able to help suppress that inflammatory response in patients with endometriosis. And it's something that is recommended to look at much more closely for patients that have endometriosis or fibroids. So when trying to conceive with any assisted reproductive technology, such as IUI, IVF, and or ICSI, we see that the vitamin D, this is a correlation here, vitamin D levels in the follicular fluid are up to 4 times higher compared to patients that have low vitamin D levels. And so the vitamin D, again, like we're seeing that not only is it just present in the serum, but it's actually present in the follicular fluid. It's reaching that target organ. And we see that the vitamin D deficiency may actually affect the endometrial lining thickness in patients going for ICSI. And the endometrial lining thickness is incredibly vital to supporting implantation and pregnancy. And resolving vitamin D deficiency can be an important part of supporting fertility for these patients. Earlier studies back in 2014-15 suggested, I think, like an increase by 6% in implantation rates for patients just with supplementing with a little bit of vitamin D. And for patients that have a thinner uterine lining, again, like, coming back to vitamin D has an important role in the production of some of those sex hormones. And so when they did a systematic review and meta-analysis, they looked at 7 studies, over 1,200 patients, and they found that vitamin D concentration was significantly associated with sperm motility. So vitamin D seems to affect not just egg health or uterine lining thickness, but also may impact sperm motility. And it seems to do that by affecting the transport of calcium into the sperm cell itself and affecting the movement of the tail there. But overall, we're seeing strong correlations between vitamin D deficiency and the risk of infertility. So again, we're seeing the high quality, they've separated this by high quality studies and moderate quality studies, but association between vitamin D and fertility, so lower vitamin D levels, decreasing the likelihood of conception there. Now, endometriosis, this is something I really wanted to mention during this presentation, because guaranteed you've probably seen this if you work with women's health or reproductive health or fertility, are patients who are just in chronic pain. And the current standard of care, birth control or anti-inflammatories can help a number of patients, but it kind of hits a wall at some point. And antioxidants seem to help bridge that gap in patients who are seeing some improvement with anti-inflammatories, but not quite where we would say they're having a good quality of life. So antioxidants seem to help a lot of these resistant patients that aren't seeing a significant decrease in pain by reducing the oxidative stress there. So endometriosis is a chronic inflammatory condition. Classic symptoms we'll see are usually painful periods, painful intercourse, and chronic pelvic pain. So this isn't just associated with menstruation, something that's present potentially all throughout the cycle. And it's usually diagnosed with a laparoscope, although MRIs can be just as effective in diagnosing endometriosis. And I think it's one of those conditions, along with PCOS, that's often missed for a lot of patients. So more times than I would like to remember the number of patients I've been told, yeah, it's normal, don't worry about the pain, it just is what it is. And doing an IVF, doing 2 IVFs and finding out, oh, actually there's endometriosis, we found it on the laparoscope, sorry. So this is something, if patients are having painful periods, or if they have a history of painful periods before going on birth control, something definitely to consider looking at in much more detail. And even patients who aren't trying to conceive, I see patients that they'll message me, I know you work with fertility doctors, saying, do you work with patients who just have endometriosis because they're living in pain almost every day of their life, taking over a week off work, some of them during their menses, and vomiting, passing out from pain. Like this isn't a way we can just kind of. I don't understand how patients like that are sent home and told, just take some anti-inflammatories and it'll be fine, when it's obviously not working for them. So, and we're not even talking about some of the hard-hitting antioxidants here. We're just talking about like vitamin C and vitamin E, by the way. Okay. So vitamin C and vitamin E both have been evaluated for the management of endometriosis, and it's been found to significantly reduce markers of oxidative stress in the peritoneal fluid when compared to patients that have placebo, and a significant decrease in MDA and lipid hydroperoxides, both decreasing 4 months after treatment with 343 milligrams of vitamin C, 84 milligrams of vitamin E per day. And they see a decrease there in pain as well. A triple-blind placebo-controlled clinical trial looked at changes in oxidative stress markers and pain scores. So looking at patients that had, again, painful intercourse, painful cycles, and chronic pelvic pain, just giving them treatment with 1 gram of vitamin C, 800 international units of vitamin E every day, just for 2 months. All pain scores showed a statistically significant decrease when compared to the control group, as well as decreased MDA levels there. So we're seeing decreased oxidative stress markers. Okay, so here specifically, what I'd like to, let me get the pointer here actually. So you should be able to see this. What I want to highlight here is vitamin C and vitamin E group. You'll see before starting the treatment, these are the pain intensity scores: 50, 66, 66 for dysmenorrhea, dyspareunia, and chronic pelvic pain. Let's go over to week 8. So the mean score is 17.56, 15.43, 12.43. Again, we haven't even talked about curcumin yet. We haven't even talked about resveratrol yet. I don't even talk about nostril. We're talking about just like vitamin C and vitamin E. And we look at the placebo group, look at the mean scores here, 51, 20, round that to 17, and we're seeing not as significant changes with the dyspareunia, chronic pelvic pain there. Another randomized clinical trial there, placebo-controlled, comparing pain scores and markers of oxidative stress in patients with endometriosis. Again, 1,000 milligrams of vitamin C, and this time 1,200 international units of vitamin E versus placebo. We're seeing chronic pelvic pain improve by 43% of patients in the antioxidant treatment group. Dysmenorrhea decreased in 37% of patients. This one was not statistically significant. And dyspareunia decreased in 24% of patients. Again, this was clinically significant, but not statistically significant. And for the chronic pelvic pain, we are seeing that for patients who have month-long, entire, almost all days or majority of days where they're seeing significant pain, that was a statistically significant improvement in the pain scores. Same thing with the markers of oxidative stress. So we're seeing, A, clinically, patients are feeling better. B, we're actually seeing on a biochemical level some of those markers of oxidative stress go down as well. Now we're seeing how does vitamin C and vitamin E exactly affect sperm health? Does it help with motility, volume, concentration? So kind of like the carnitines like we looked at earlier at the start of this presentation, we're seeing different results there. So we see it might be beneficial for sperm motility. It may help to reduce sperm DNA fragmentation index after 2 months of treatment, and may help increase pregnancy rates after 3 months of vitamin E supplementation. So by the way, this is just treating again the sperm, so just helping with antioxidants to support sperm integrity, DNA integrity, overall sperm health. We actually see that pregnancy rates may start to go up in those couples. And when we look at 300 milligrams of vitamin E versus placebo in a different trial, 21% of patients were able to conceive naturally in the treatment group, and 17% increase in sperm motility was also observed. So again, we're seeing an increase in sperm motility here in this other trial. Greco et al., they've combined vitamin C and vitamin E again for 2 months, and they found that DNA fragmentation index went down by 13% compared to the control group. And when they started this treatment, all patients had a DNA fragmentation rate above 15%, which is clinically significant. So once it's above 15%, we would consider the DNA fragmentation rate to be elevated. So just with the vitamin C and vitamin E 2-month period, we're seeing a decrease in the DNA fragmentation rate there. Now, see, this is this is very interesting. As a side note, we're seeing that vitamin C and vitamin E may improve the sperm quality without really reaching this full 72 to 74 days that it takes for sperm maturation to occur from start to finish. So we're seeing that the changes are most likely occurring in the seminal fluid. It's affecting sperm cells that are already there by reducing the oxidative stress and supporting their health. So not necessarily that we have to wait a full 3 months. You're seeing just in 2 months the DNA fragmentation rate may start to improve. So antioxidants are by no means the be-all, end-all of supporting fertility and solving infertility, but they are a huge cornerstone of supporting reproductive outcomes for both sides, both partners, for egg quality, sperm quality, and also quality of life, like we looked at for patients that might have hypothalamic amenorrhea or hypothalamic hypogonadism, or patients that have endometriosis with chronic pelvic pain. So these antioxidants are something that we really need to have an important discussion with patients about, and specifically looking at the right antioxidants that's been clinically observed and research for that particular condition for the right patient with the right condition with the right dose. And with antioxidants, that dose may have a potential impact on the results. You see some of these combination products on the market, and they're like, oh, fantastic combination of antioxidants, like 10 international units of vitamin E, 50 milligrams of vitamin C, and it's like this is nowhere close to what's actually being used in the clinical trials. So we can't really go in with a lot of faith that's going to have the same impact that we would expect as we would objectively see in patients, in these studies, and clinically seeing patients who have he's seen improvements in the sperm parameters. And I have a stack right now of case studies that we're looking at getting published, but just one, male patient after the other, coming in, low sperm motility, low sperm concentration. They want to do ICSI. The doctor said there's nothing that can be done. And within 3 months, we're seeing counts going from less than 10 million to above 50 million. Or patients, with even less than 1 million, seeing huge increases. We're talking like, 40, 50 million sperm cells in concentration. Very commonly, patients with low sperm motility that we know probably have high levels of oxidative stress, higher risk of elevated DNA fragmentation rates, and just with the right antioxidant treatment, among other lifestyle changes and doing like a holistic support for that patient, but antioxidant being a cornerstone of that treatment, seeing these patients increase sperm motility from less than 20% to over 40, 50%, like it's nothing, and going back to the fertility clinic, like they would not be able to recognize that from the sperm parameters. If they just gave a sperm parameter test, they would not be able to recognize who this patient is. And that's something like I would say I see fairly consistently when we're using the right antioxidants for patients there to support fertility. And remember, sperm health is no longer just about helping the patient conceive. It's looking at potentially risk of miscarriage and supporting potentially the health of offspring for the duration of their life. So Kaylee, I think at this point we can open up to some questions.
Yeah, a few are coming through, and some good comments saying thank you for a great presentation. I agree. Tons and tons of information and very valuable. So thank you. I can go. I know we have our teammate Ryan on the back end helping to answer some of these, so thank you. But I thought we'd go through some of them anyway, so everyone can hear answers, and we can have it on the recording too for those who aren't here. So kind of going back to the beginning, there was a question. Now also you have to bear with me on some of the pronunciations of these products and antioxidants and minerals, but would acetyl L-carnitine have any effect on short luteal phase?
Actually, very interesting you mentioned that. So it may, and we see that again because the carnitine can impact, the acetyl L-carnitine particularly may impact FSH and LH production from the pituitary gland. Patients who, particularly with PCOS, that have this hypothalamic hypogonadism, they're not really producing a lot of progesterone or estrogen. So the acetyl L-carnitine in those cases may actually be of benefit to help support healthy sex hormone production. So we see the acetyl L-carnitine, when it crosses the blood-brain barrier, may increase gonadotropin-releasing hormone, may increase FSH-LH, which downstream would potentially increase estrogen and progesterone production as well. And there is some research on vitamin C, limited research, mind you. And I find certain herbal compounds may be actually better suited for low progesterone, but usually we'll look at a combination. And a surefire way of getting the progesterone levels up is usually using the actual hormone. So I find, if patients are responding with increased progesterone levels for the right treatment within a couple, 2 to 3 months max, we're usually having a discussion actually utilizing hormone treatment there as well.
There's a ton coming in too. So another one going back kind of to when you were speaking on melatonin. So when treating egg quality with the treatment of melatonin, is it possible to improve current egg quality? And if yes, how long should someone be on melatonin to get these beneficial effects?
So 3 months is the cutoff. Usually takes 3 to 5 months to support egg quality. And yeah, so this is what we're seeing. So a lot of these antioxidants, we're not just seeing that it can help preserve egg quality, but one of the main mechanisms by which we see a decrease in egg quality is because the level of oxidative stress is going up. So here's the level of antioxidants, here's the level of oxidative stress, and with age, antioxidants go down, oxidative stress is now relatively higher than the antioxidant. So this affects egg quality. This starts, at age 35, usually we start to see this really kick in and start to gear up. So by giving exogenous antioxidants, we can kind of close this gap in so that oxidative stress is no longer impacting the eggs. And, you're like, how do the eggs recover? Well, the DNA of eggs, it's kind of like an accordion. So when they're in their they're arrested states, or they're not part of the growing follicle pool, it's actually compressed. And the DNA that's compressed is actually very well protected from this chemical stress. Now, when the hormones start to select that follicle and, say, okay, we're going to grow this follicle now, we'll start to open that DNA up like an accordion, and now it's very vulnerable to oxidative stress. So that change, in the egg quality is really reducing that oxidative stress, increasing the antioxidant capacity. So as we mature, other follicles that have had this compressed DNA, as we open it up, they're not facing the same toxic environment. And usually, like the same thing with the dose. I personally have not seen any changes in egg quality. In someone who uses 3 milligrams versus 10 milligrams, usually, even a small dose, because our endogenous production is usually relatively low at nighttime. So even if you give 3 milligrams, you're giving, sometimes up to 10 times higher level of melatonin that patient's going to make at nighttime anyways. So that very, sounds like a low dose, but it's actually quite high compared to what the body's used to, and enough to concentrate in the follicular fluid there.
Now going back to some questions around that endometriosis slides, there's a few that came through. So how long would you continue supplementation in these patients to help with those pain scores that you saw? They know the study was for 2 months, but is supplementation to continue past
that? This is kind of the unfortunate part of chronic conditions. Okay, like they're hard to treat, very quick to come back. So especially with endometriosis, and I'll mention this to patients because they'll come in usually a month after starting treatment, like, doctor's saying the pain, it's so much better. I haven't felt like this in years. Thank you. And it's like, don't stop yet. Because if you do, within a couple of weeks, that pain's coming back. So it's just the nature of the condition, unfortunately, that the oxidative stress is very high locally in the tissue where the endometriosis is located. And that decrease in oxidative stress usually requires constant support. So as soon as you stop taking some of these antioxidants, especially the water-soluble ones, it's really out of the system. We're not getting these high therapeutic doses anymore.
And I think kind of along those lines, there was a question of, can these antioxidants be taken preventatively before fertility treatments, kind of as like a way to prevent pain or anything reoccurring, I guess?
So this really comes down to patient cases. And for example, if you know the patient has a condition that's putting them at higher risk of lower egg quality, lower sperm quality, this is an important conversation to have with the patient and we call it, cost benefit analysis and risk benefit analysis, sorry. And we basically want to assess, are the benefits of antioxidants going to outweigh the potential risk of because nothing is free. Everything has a potential risk there. Usually the risk of harm from a lot of the things we've discussed is they've got very high safety profiles, but still we need to assess that, case by case. If you have a 25-year-old patient who's very healthy and, say has like Asherman syndrome or something like that, giving antioxidants isn't necessarily going to benefit. They probably already have quite excellent egg quality. So again, choosing the right patient for this. And antioxidants are not a be-all, end-all. It's not going to prevent fertility issues for everyone. But I will say one of the groups of patients that are often not treated that require treatment are usually patients that produce sperm. So the low antioxidant capacity, and this is the main change we see after age of 40. We see how like fertility for women can decline after age 35 or 30, whatever that mark, and that's so, that age is, I find, it's kind of an old school technique. Like we've seen patients who are 38 and have the egg reserve for 32-year-old patient, seen a 19-year-old patient who has the egg reserve for 45-year-old patient, so that can vary quite a bit. But in general, we see that egg quality starts to decline with age. For men, we see that the oxidative stress starts to go up. So after the age of 44, about 4 out of 10 men are estimated to have hypogonadism, so low testosterone, and also lower antioxidant capacity. So the main change we'll see with men after a few years. So sometimes you'll see these patients where the male partner is above the age of 50. The main thing you need to be looking at is DNA fragmentation rate. That's usually the issue that we'll see, and that might hinder chance of success with these fertility treatments, unfortunately. So antioxidants can be a very important therapeutic tool for that particular group of patients.
Actually, a question came in on DNA fragmentation. You may have touched on it already, but does DNA fragmentation, or can it contribute to recurrent miscarriage in the second trimester as well?
Not as likely. I can't say won't, but it seems to contribute more to the first trimester. So when you look at miscarriages, we usually divide them into two categories. We're called a euploid miscarriage and an aneuploid miscarriage. So euploid means chromosomes are good, like we're seeing 46 healthy chromosomes, and then aneuploid being there's an imbalance. Usually there's a trisomy, there's an extra chromosome. And antioxidants, they can't necessarily change once someone's pregnant, obviously, the number of chromosomes. But if you give it to the partner, the male partner, 3 months ahead of time, if it helps to reduce the DNA fragmentation rate, it may help to provide healthier quality genetic material and may reduce the risk of miscarriage in the first trimester. In the second trimester, we're looking at other causes, anatomical, usually if there's polyps, fibroids, T-shaped uterus, other potential genetic causes. So we're looking at other causes there usually. If it's related to the DNA fragmentation rate, it's usually the research I think has been mostly looking at first trimester. But again, the patients that do make it to the second trimester, they're not the types of patients that are being included in a lot of these studies anyways. So it might, but not that I'm aware of.
Okay, I think we could probably do a couple more questions if you're okay. There's a couple questions on kind of specifics on your thoughts on things like vitamin A and NAC. You may have kind of touched on them, but we got a few questions on NAC. Your thoughts on NAC support for oxidative stress?
Yeah, it's one of those antioxidants that has been.
Oh, sorry, there was a little more specific. Specifically for someone who has endometriosis with high glutathione urine markers. Sorry, that was like a long-winded question.
So that's
but really a few of them.
In general, I will mention that NAC is one of the antioxidants that has been studied for egg quality. It is something worth looking at. Supporting glutathione levels in the body, one of the highest endogenous antioxidants. And simply because lower glutathione levels in the follicular fluid have been associated with lower quality embryos, lower chances of success with IVF. So supporting healthy glutathione levels through NAC is an important avenue to support fertility for these patients. And that's how it is with antioxidants. It's usually not one or the other. We're doing synergistic formulas that work together. I find antioxidants usually work better together. So endometriosis, low egg reserve, low egg quality for men as well, potentially looking at NAC. It is quite a versatile nutraceutical. And PCOS,
I know that, as I said before, we're conscious of your time and everyone else's time. There is one question, though, I think that we can kind of end off on, and it'll benefit everyone. I know you have a website on the screen as well as social media. It looks like also a podcast. Is that what I see there as well?
Yes. Yes, I share.
One of the questions, yeah, and we can share that too, and I'll make sure we put that in the follow-up. But one of the questions was, can you recommend any resources that you use when you recommend the right dose for the right patient? Anything you specifically use that's helped you?
Excellent question. And that'll come down to the research papers themselves. So those are usually our resources there. I don't have a chart, like, this patient, this age, this not, but usually the research trials themselves. So if you're looking at using these antioxidants, strongly encourage you to look at the actual clinical trials. Go on NCBI, look at PubMed, and pull up those research papers. Look at what dose is actually working for your particular patient with that particular age group, that particular case history.
Yeah, well, this has been amazing. I know I have learned a lot in the last hour or so. I know very valuable information for our attendees, and we thank you, Dr. Singh, for being with us today. I hope we can continue to do more webinars in the future, and that we get to see you again. I know that our attendees, with the amount of questions that came through and the amount of thank yous, I think it was a great presentation, and we loved having you here with us.
My privilege. Thank you so much.
Just a quick reminder too, to everyone who is still here, there will be a follow-up email that will have access to this recording, as well as the recording lives on the Fullscript website, fullscript.com/webinars. So you can find that there. I will include Dr. Singh's email and social and any other little resources we can find along the way in the follow-up and on that landing page, so we can provide attendees and registrants with everything we possibly can. Again, thank you so much, Dr. Singh, for being here, and we hope that everyone enjoys the rest of their day.